morning, everybody. This is IC90, the pelvic spine connection, importance in seating and wheeled mobility. Our presenters this morning are Tina and Allie, and I am going to go ahead and turn it over to them to give their presentation.
Awesome. Thank you. All right. Thanks everyone for joining us it's an early morning if you're on the East Coast, and even more so if you are on the West Coast with us today. So we appreciate everyone showing up. Today, we're going to go over our presentation of the pelvic spine connection, the importance in seating and wheeled mobility. All right. So my name is Allie Speight. I'm an occupational therapist, a RESNA certified ATP. I'm located just outside Toronto, up in Ontario, Canada, and I've been an occupational therapist for 12 years now, going on that. So previous to my role that I'm currently in, I did practice in home care, long-term care. I worked with Veterans Affairs up here in Ontario as well. But currently I am the Director of Education and Training within Motion Composites. I'll let my colleague Tina introduce herself here.
And I'm Tina Roesler. I'm Director of Clinical Business Development with Body Point. I previously worked with Allie as well, so we submitted this program when we were still working together. I've been a therapist for about 25 years, actually closer to 30 now. I don't like to admit that. I've practiced in various settings, but in the last few years, I have worked for Motion Composites. I was with Thai Light for 10 years and also the Roho group. So I've been around the industry for a while.
That being said, I do think we covered it, but we'll just confirm and do let everyone know that we do work for two manufacturers, ultra lightweight manual wheelchairs, seating, as well as positioning products. And to be honest, it's what gives us a bit of specialty in what we're talking about here today, which is great. So, but just putting that out there for everyone to know. Our learning objectives that we're going to go through today. So we want to be able to identify spinal and pelvic landmarks that are crucial to that seated posture, as well as understand changes to spinal and pelvic anatomy as it pertains to development. And then definitely learn how external seating and positioning devices can influence posture and mobility. So really, with all of these objectives added up together, they're going to help us move very thoughtfully and intentionally through each individual client that we see, through that process of assessment to equipment with each individual client. So that's really our goal here today. All right, before we get into a bit more of the reality of that seated world, we're going to talk a bit of ideals, right? So the ideal seated position. We're going to start with that pelvis, look at that slight anterior pelvic tilt, our level pelvic landmarks, our PSIS, our ASIS, our ITs, in that nice neutral position, which is going to, as we move down those lower extremities, go into that nice neutral rotation of our femurs to allow for that seated position. As you work your way up from that pelvis, we're going to start looking into normal lumbar curves with a little asterisk there, and we'll get into that in a bit more of what is technically considered normal. But a neutral trunk alignment, level shoulders, over your hips, neutral cervical spine. And so what makes this ideal? Why is this considered our ideal in seating? It's technically a position, if you're able to get into it, that's going to allow you to remain seated, which is very functional in our world as well as in our clients' world. But we also know it's going to help our body require less effort to have to maintain it, right? So less effort on our body, less strain, if we can get into it. This is how we would ideally be seated. We would be in a balanced position. But here's your first quiz of the morning. How many people are sitting like this? I just talked about it for a minute, and I'm not actually sitting like this with my legs crossed and my pelvis is not centered. I am going to blame that on being 8 months pregnant, but if my colleagues who know me well do actually know that I don't sit like this normally any time of the day. And so although it is ideal, it's not always the reality of what we do see within our world. Ideal or not, what does the seated position or our posture that we're in mean? Well, it has a lot of effects on our daily lives. So within the seated position, there can be secondary complications. So whether that's leading to our skin health, pressure injury risk, redness, breakdown in any manner, can be a factor of those secondary complications. There's actually, humans weren't designed to sit, technically. There are beings on this earth, not the human species, that were designed, and evolution has allowed them to stay in this seated position without some of these secondary complications. We're unfortunately not one of them. And so we do have to consider what that seated position does to the human skeleton, whether it comes to skin health, pain, pressure, those beautiful things that we talk about and deal with on that daily basis. One of the other things that it impacts and is related to those secondary complications is, of course, comfort. The general term that we like to use when we're talking about technically sitting tolerance. How well can someone maintain that position? Can they maintain it to get through the function that they want to get through? Whether it's completing ADLs, whether it's relaxing, watching a movie, being with friends, comfort and their tolerance and their ability to maintain that position is a big factor of the posture that someone is in. Moving on to the other one being function, and you can sort of see these are all sort of building on each other as we go through them. But the function ability of posture is not only going to allow life-sustaining functions like respiratory, GI functions. So whether they're life-sustaining or comfort as well within these, or preventative for issues that can happen because of a seated posture and their effect on these bodily functions. But as well as an occupational therapist, my favorite, that distal limb function. So whether it is movement within your lower extremities that are going to allow you to foot propel a wheelchair, or whether it's bilateral upper extremities so that you can do those ADLs, IADLs while feeling safe, while feeling meaningful within your life, posture has a big impact on the ability to do that. And then another one that we don't always consider in our field as much as we technically should, but our visual field. Right. So it's a big aspect on social interaction, your safety with our mobility devices. Where are we placing that visual field for our client so that they can functionally and socially and safely move throughout their environment and interact? That was all perfect and beautiful in the natural process of seating and posture. These are a few pictures of a bit more of that reality. People who are doing real world things that sometimes don't put you in that what we consider that ideal posture. So whether you're flipping your toddler over your shoulder while in your wheelchair, which is getting you out of that ideal position, or no matter the miracles we can pull off in our industry, that ideal position may not be right for you. This is a bit more of that reality of what seating is in our industry, but focusing on what the ideal was and where we know our bodies tend to like to be if we are in that ability to get to the ideal position is a really great base of where to start when we're looking at things that can affect seating as well as mobility around that. We're going to take a few steps back here and dive a bit deeper into anatomy and the structures that play a role in the seated position. And I'm going to pass this over to the physiotherapist between the two of us, Tina.
So good morning, everybody, and thanks for the intro, Allie. So I think today, some of it's going to be a little bit of an anatomy review. A lot of us have been practicing for a long time, or maybe not as long, and sometimes we forget to go back to the basics, right? We get so caught up in the assessment process and what we're doing and matching the equipment, and we sometimes forget to look a little more deeply at the body and what we're doing or what we're trying to do with the equipment. So we're going to go over some general anatomy and remind you of some things regarding just anatomy and development and functional anatomy. And we're going to start at the pelvis because that's where we start in seating and positioning, right? So it really is what dictates one's alignment and ability to function. It provides our base of support. We do want to remember the term closed kinematic chain, because remember that the pelvis, when you are sitting, your pelvis to your head and down to your feet, if they're supported, act as one closed chain. So if you guys remember what that means, if you're newly out of school, you'll remember more regularly than some of us would, is that anytime I do something to one of those segments, it's going to impact the other. So if I change the position of my trunk, I have to look at what that does all the way up to my head and all the way down to my pelvis and vice versa. So I can level someone's pelvis, and we've all probably done this in the clinic. You're focusing on the pelvis, they have an obliquity or they have a rotation, we correct it. And then you look up at the person, and they're leaning sideways over their chair or over your shoulder. So we have to remember that. And also the same holds true. The proximal stability promotes distal function. We've learned that a lot. We talk about it a lot, and it still is correct. We want to look at minimizing postural deviations. And if we can start at the pelvis and get pelvic stability, we can help minimize that over time. And it will also help, like Ali talked about, decrease risk for secondary complications. Next slide, Ali. So I do want to review pelvic landmarks because I think this is important. And sometimes I have people go, well, why do I need to know these? I know how to do seating. I can see what I see. I think it's important that we remember exactly where they are. If I were there live with you, I'd be telling you to palpate most of these on your own. So if you want to, you can go ahead and do that. I always like to start with the ASIS. So the bony prominence at the top of your hips. That's important because it kind of helps dictate what's the position of the pelvis. It helps us document that. It can also help us look at where do we want to place things like postural supports. The acetabulum obviously is the hip socket. The ischial tuberosities, we all know that these are very important when it comes to seated stability, especially when you start talking about seating surface interfaces and the ability to envelop the ischial tuberosities and give support. We don't want someone balancing on those 2 points, right? Because then they're going to be unstable. We want to make sure we encompass that. The symphysis pubis, people think, well, that's not really a relevant pelvic landmark for seating. Well, you have to consider when people are in abnormal postures that we don't want weight bearing on that area because it can really cause some big problems. And I have seen with some people who have a very strong hyperlordosis that they're actually almost weight bearing on their symphysis pubis. And we want to try to avoid that. And we don't want to put a lot of force on that area either. Lastly, I would talk about the PSIS, which I would have you guys all palpate on yourselves. And most of the time is where those little indents are on your back. You can see them on a lot of people, not everybody. Why is the PSIS so important? Well, when we start talking about seating and seating devices like back supports, a back support really should be supporting the PSIS. We're going to talk about normal lumbar curves. And really, we don't want to support the lumbar spine. We want to support the posterior pelvis to prevent the pelvic rotation. So remember these landmarks as we go along and as we start to talk about equipment and how we apply that as well. Next slide, Ali. The other important thing are really the basic pelvic tilts. So we're going to review this. All of us know this. I would ask you as you're sitting in your office or in your bedroom or your living room to go ahead and do these tilts. And go ahead to the next slide, Ali. Oh, sorry, next one again. I always like to show this picture because it's an actual person. So I want you guys to go into a posterior tilt, and as you're sitting there, let your head just fall forward as it wants to, and then try to lift up your arms up over your head. And try to take a really deep breath. So if you take a really deep breath, it's not as easy, right? And then I want you to come up to a neutral pelvis. So you're almost on your ITs, but not quite. And I want you to do the same thing. I want you to lift your arms over your head. And I want you to take the deepest breath that you can. I should make Ali do it too, since she's on screen. And then in the third position.
Morning yoga, Tina. I should be doing this. I'm sitting here going, this would feel really good.
I want you to go to a slight anterior tilt. So you should feel your ITs right underneath you. Your feet should be on the floor if they can be. I don't know where you all are sitting. You can feel that you grow a little bit. Your spine feels in a more neutral position. And I can reach my arms all the way over my head. And I can take the deepest breath possible. So you can take a deep cleansing yoga breath, Ali, if you like.
Did feel really good. I actually laughed because I was like, oh, this is the ideal seated position.
Right. So it's really interesting. And as you move through that position, you can feel the change in your diaphragm, in your abdomen, in your upper extremities, in your head position. So even just that anterior posterior position of the pelvis has a huge impact on function. Ali, if you can go back one slide. We also have to assess lateral pelvic movement, so obliquities, right or left. So if someone is leaning more to one side or the other. The only thing I want to say about this is we're going to discuss actual spinal motion in a few minutes and talk about how we can address this but it might not always get the result that we're expecting. And some of that has to do with the functional anatomy of the spine and pelvis. So we're going to start to talk about how the spine moves in relation to the pelvis and how sometimes our seating interventions might be limited because of that. But let's go ahead on and finish up with the pelvis and talk about also the hamstrings. So we're talking mostly today about the bony makeup of the spine and pelvis, but especially in our field in seating, we also have to remember that there's all these things that connect all those bones together. So things like muscles, ligaments, tendons are all going to have an impact on position. So I do need to recognize the influence of the hamstrings on the pelvis. Remember that they attach to the ITs and to the back of the knee, right? So they cross both the hip and the knee, and they are going to influence that. So if you have a tight hamstring and you're trying to put someone's feet, say at a 70-degree angle and their hamstrings are tight, it will have the tendency to pull them back into that posterior pelvic tilt, right? Or if they have high tone and they increase tension at the hamstrings. So it is going to affect the isolated amount of hip flexion and can promote sacral sitting. And you can do things in seating and positioning to minimize that impact, such as having a more fixed front end or a more bent knee position in the seated posture, which can then help me be able to get to that slight anterior tilt. Next slide. And again, I just want to reiterate the whole idea of the closed kinematic chain. So the functional consequences means that movement at one joint is going to cause every other joint to move, and usually in a pretty predictable fashion. You can't separate the spine and pelvis. So as much as sometimes we have this tendency, like if I see someone with a scoliosis, my first thought is let's go look at their trunk. But if I look at their trunk without looking at their pelvis, I'm not going to get the full picture. This gentleman was an old client of mine from years ago. He has a pretty severe pelvic obliquity, as you can see. It's very obvious. I can correct that somewhat, but what happens when I do that? He has a fixed scoliosis. So if I try to fix that pelvic obliquity, he basically is sideways over the chair. So for him, it was more important to be able to reach his wheels and propel, to be able to look someone straight ahead. And we really just had to make sure we protected and knew that he was at risk for skin breakdown and for other problems related to that posture. So it's really important to realize it is a closed chain and we can't always fix all of the chain. So now we're going to go into the fun part. This is Allie's favorite part of the presentation. We're going to talk about the vertebral column because it's very easy to forget sometimes the functional anatomy and the basic physiological things that we learn sometimes in school, because sometimes we learn them very early and then we go into the clinic and we're really more focused on function and trying to correct postures, but we have to remember what we're working with, right? So the vertebral column has four functions. It's protection, obviously, for the spinal cord. It's support. So think about it. The spinal column supports all of the weight above the pelvis. So it has a pretty big job. So it has to be a pretty strong structure altogether. It is also the central axis of the body. If you think about motions that happen anywhere above the pelvis, they all initiate, start, or finish at the spine, right? Even the act of lifting my shoulder or reaching across my body, there's spinal rotation that's happening there too. And it has both roles in posture. So therefore, it has a role in both posture and in movement, which sometimes don't work well together, right? They're kind of contradictory if you think about it. But the spine is very significant in what we do as far as seating and positioning professionals. Next slide, Allie. So let's review it a little bit. Remember, we have different types of bodies of the spine. We have 24 pre-sacral vertebrae, 5 fused sacral segments, and 4 coccygeal segments that are also fused. So really what we're going to address mostly with seating and positioning is we're going to talk about those pre-sacral vertebrae and the differences and the motion that happens there. So let's look at articulations or joints of the spine. This is sometimes my favorite slide because I think we forget. So we look at the spine and we think we're thinking this big unit with lots of joints, but there's rotation, there's lateral bend. That's what we see. What we have to remember is that each segment, so each of those 24 areas, or 22 really when you look at it, have 6 joints between them, right? So that's a lot of joints that we're trying to manipulate or impact with relatively simple external devices, whether it's our hands or a back support or some other kind of positioning device. So what you have is you have the joint here. Are you guys able to see my cursor on the screen pointing?
No.
No. So you have number 1 is no, you cannot. Okay. So anyway, you can see the superior body with the disc above. So there's a number 1 on the top. So you have the top of the spine with the disc above it. And then below, you have the disc below with the bottom of the articulation. So the inferior body. And then you have the facet joints, which a lot of us forget about, but they are these tiny little joints, 3 and 4 and 5 and 6, that articulate with similar tiny joints of the vertebrae, both above and below. And those joints, while they don't have a lot of movement, they really can dictate the amount of rotation, or if they get stuck or if they don't move properly, it can limit the amount of rotation or lateral movement or flexion and extension. So we are trying to impact this extremely complicated system with relatively simple applications. So think about that when you're trying to position someone and you're frustrated because you can't get that ideal position that you're looking for. Next. The other thing, so this actually gives a better picture of the facet joints because it's from the side. So you can see the little arrows. As I flex and extend, those joints also move. There's some rotation and flexion at those joints as well. So they're very small joints, but they can have a big impact on what we see at the spine. Next, Allie. And this is the part that makes it so complicated, is that spinal motions, what we see is flexion, extension, and lateral flexion or rotation, right? But none of those things occur in isolation. So we might see flexion at the thoracic spine, but all of these motions happen in what's called coupling motions in the closed kinematic chain. So it might not just affect the one level we see it at, it can affect all the way down or a few segments down or up. So for example, on this diagram, this kind of gives you an idea. If I see side bending to the left, I'm also getting rotation to the left and flexion at the facet joints. So it's not as simple as I need to quit the side bend. Also understand you're also trying to impact rotation and some flexion that's happening too. So we really have to be cognizant of this to understand the complexity of movement and of postural support, to understand what we're trying to impact. I think that's one of the key takeaways, is that it's a complex system. We're using fairly simple external supports when it comes right down to it. And we're not always going to have the impact we think we do, because it's almost impossible to really impact the level of the facet joints very simply just with external devices. It doesn't mean we can't work on other therapy interventions to try to impact that, but it just means that maybe what we think would work doesn't always work. Next.
Oh, sorry.
Oops. There are variations in the vertebral articulations too. So, we can't keep it that simple. At the occipital atlanto complex and the atlantoaxial complex, so your C1 and 2 and your C1 with the brain, you can see that you have, or the skull and the brain, you have different, oh, Allie, you can run the cursor over it. That's why.
I know, I just did that. I realized.
So you have different articulations there. For example, C1 and C2 are mostly rotation and this motion. It's not quite the same. The thoracic variations, let's add some more joints, because let's attach the ribs to the thoracic area, right? So you're going to limit actually some of the motion there, especially at the T1 through T9, where it's closed also at the sternum. So you're actually adding joints upon joints upon joints. And then the sacral variations is that you have 5 fused vertebrae. So it's very different than the rest of the spine. But so just remember this as you go along. When you're starting to get kind of caught up in seating and positioning, again, sometimes it's easy to look at the big picture and the functional aspects and what do I see externally, but we have to remember what we're trying to impact. Next. So just as a kind of review of what we just talked about, what is mobility of the spine and pelvis influenced by? It's influenced by the orientation of those tiny facet joints. It's influenced simply by the structure of the spine and based on what area of the spine it's in. It can also be influenced by things that we can't see, like disc size and fluid content. For example, as I age, I might see someone get more kyphotic because that disc fluid reduces or those discs are compressed, right? I can't impact that with my seating. Ligaments that stretch out or maybe are too tight. We have all the other bony articulations within the spine. And then also don't forget all the muscular attachments, which we really don't have time to address because we could do a full day presentation just on biomechanics of the spine. So we just wanted to give you a little taste of those biomechanics, and we're going to kind of continue with that and talk about how those biomechanics, what happens during development with the biomechanics of the spine and how we may or may not be able to influence it.
If we could do polls, I would laugh right now about how many people just wrote a list to call their chiropractor because that's all I want to do right now.
So we're going to talk about normal spinal contours. So we're going to start talking more now about development and what happens over time with the spine. So what we see in most models is a cervical lordosis, a normal thoracic kyphosis, so a slight kyphosis of the thoracic spine, a lumbar lordosis, and a sacral kyphosis. So what I want you guys to remember too is all of these models that we see, even the pretty picture of just the spine without any body part on it, all of these models represent a standing adult model. So that is really critical because there are a lot of changes that happen as we develop that we have to pay attention to when we're trying to do seating and positioning. I also want to point out first to the lumbar curve is that those models are of a standing weight-bearing adult, right? So when we weight bear, our lumbar curve gets more accentuated as we weight bear through those discs and through those bones. When we are seated, we should not expect to see the same kind of lumbar curve. When you're seated, your lumbar curve lordosis actually slightly flattens out unless you have some abnormalities. Like you're 8 months pregnant. I don't mean it as an abnormality.
Mine's pretty flat, I'll tell you.
Yeah.
Right
so it really just, it depends. But so you need to remember that these are normal spinal curves of a normally developed adult weight-bearing adults. Okay. So the contours have to develop. Go ahead to the next slide, Allie. Normal and abnormal development will impact those curves and that seated posture. And I'm going to actually turn it over to Allie, and she's going to talk about the development of these normal curves. And I want you to actually focus too on these two differences. This would be a small baby or a fetus. It's a single curve. And then in the weight-bearing adult, you can see how it changes over time. So we're going to talk about how those changes happen, when they occur, and what the implication is. And I'm going to turn it back over to Allie for that.
Thanks, Tina. Erin in the comments said such a great review. Thank you. And every time I see Tina present this part, I'm always like, it is a good review. And it made me really happy I didn't go into being a chiropractor. So like every great parent, I'm going to exploit photos of my son here to show you those curves that Tina was talking about. And I was not a pediatric therapist. All of my colleagues know that. I did adults. I did mainly older adults in my clinical practice, but like having a kid does, it teaches you a lot of things. And it kind of put two and two together, at least for me, whether you have kids or not, it starts to make sense that these curves do actually have to develop. And that initial picture that Tina had on the previous slide is you really start to see that those babies are born with that one big kyphotic C, right? So those two primary curves, they're called. So of the 4 curves that you have in your spine, 2 of them are those primary curves, and those are the ones that develop in utero. So the thoracic and the sacral kyphosis. And that's why, I mean, you can see little James on the left there. He's just a C. He's curled up. He has no posture to him when it comes to it, or that is his posture. It's just that kyphosis essentially. And then you can sort of see that as we begin to change over time, and as you go through what would be considered that normal development, things will start to change to give you that functional seated position, which tends to come. And then again, if you're on that normal track, that functional standing and walking position as well. So if we move into that, we'll just follow James through a few of his milestones here. We start to see the beginning of those secondary curves, right? So the lower doses that come from the cervical spine, but as well as the lumbar spine as well. So as those babies get into prone lines, so all that tummy time you hear tons about, they start lifting their head and they start turning their head, you can actually begin to see that development of the cervical lordosis around 6 to 8 months. You can see James and my little nephew there practicing that, and I'll say Jack is actually well ahead of him there on the right, in getting that cervical lordosis that we start to see, that's going to help with that visual field and going to help with that positioning of the head for function. The lumbar,
and also I'd point out too that in the act of doing that, it also changes the orientation of the facet joints, and it also changes the length of the ligaments as well as you go through that. Sorry, go ahead.
No, absolutely. Lumbar lordosis is going to start to begin to develop a little later. And this comes through that weight bearing through the lower extremities. You can see James, it's unfortunate that it's a front picture, but that's all a mom cares about, I guess, when taking photos. I'm going to have to take better ones on this next kid coming. But you can actually see even from the front view that exaggerated lumbar lordosis to get that balance as he's learning to walk there on the right. And that was right around 12 months for that. So we do get that curve that starts to develop through weight bearing, through those lower extremities. And really all of these things, kids, adults, early adults, no matter what it is, all of this is really telling us that we have a very good reason here to start promoting and pushing towards that 24-hour positioning, right? Yes, this is a presentation on that seated posture and what we can do in terms of that within our industry, but there's that whole other section on where should you be when you're not seated? What position should you be placed in? And like I said, this can go for pediatrics right through geriatrics, and saying, what are we doing in the other positions and the other time when we're not as concerned with our mobility that can either assist or prevent future issues that can happen with our positioning. So moving towards looking at other surfaces, not just sticking to our mobility, is we can really start to see, like I said, whether you're younger, whether you're older, it can start to promote other things within positioning. That's sort of working through the normal process, right? Of how we would develop, what it would take to be able to get into where we started, that ideal seated position that has so many benefits. There's a lot of realities in our industry and with the clients that we work with that do bring on developmental disabilities. And so it doesn't allow that normal developmental process, but it doesn't mean there's not stuff that can be done. Right. And so Tina does know a bit more about this little guy that we're showing here.
So this little guy is, I think he's 15 now in this photo, and we've been following him at Body Point for a few years. And this is his new chair that came in. We did not participate in this particular evaluation, but you can see he has a forward head and he's really having to fight to look up. So he can actually control his head. He actually has a switch on that headrest that you don't see that they added to this chair. But part of the problem is because since he was little, he never went through that time of lifting his head up. He never went through prone. He really doesn't have great head control. And he really needs some assist if you want him to maintain his head in a position all day long. So his previous chair actually had more tilt in it, just a little bit, so that he could rest against the headrest. He could still use his head on command, but he gets very tired. Those ligaments at the cervical spine are stretched out. So you have to understand that if you're dealing with an older child or an adult with a developmental disability, that if they didn't go through those normal stages of development that Ali talked about, we may not be able to, for example, he's never going to have perfect head control because there have been changes with the ligaments and the orientation of the joints at the spine. So we can do things though within the seating system to help him have better head control and to maybe be in a better position and a better visual field longer times during the day, realizing that he can hold his head up, but he gets very fatigued very quickly. And then this is the position he ends up in at the end of the day, right? So we just have to kind of work with that and realize that we're not always going to change those over time. I know some suppliers and therapists who sometimes have said, well, if I leave their head this way, then they'll work at it and they'll get stronger. If they never went through the normal development, that may not work. So we just have to be careful and understand that there are limitations. Even the development of the lumbar curve. A lot of times we hear people say, well, let's accentuate their lumbar curve because that will make them sit up better. But again, it's posterior pelvic support that we want, not making a lumbar curve that hasn't existed because maybe they haven't done any weight bearing activities. So consider that when you're working with kids with disabilities or adults with developmental disabilities. What we see might be what we get at some point. I don't want to be discouraging, but we can impact it still.
I was going to say the opposite, Tina. It's not discouraging. It's pointing out the reality in our world and also giving us the tools to be able to educate family and caregivers on why sometimes we can't get to what everyone wants, which is the ideal, right? So I think it's very much a reality, and the better we go back and realize those steps, the better we can educate that moving forward, which we know is half of our job within this industry is truly being educators and advocates for our clients and knowing those realities.
Yeah, it's easy to forget the why and just try to fix it first.
Yeah, absolutely. And like I said, as someone who worked with adults and older adults especially, I will be the first person to admit, I don't think I ever asked any of my 80-year-old clients or their caregivers at the time what developmental path they took, right? If I saw like this gentleman that we have here with a kyphosis, I don't think I ever wondered if it had happened at the age of say 20 because of something or anything like that. I just sort of worked with what I worked with and looked to the past few years, but going in, and we'll get into that more of that assessment process, but we can really start to understand that knowing that whole path is a huge thing. So that being said, we did talk about those abnormalities based on development, but there can be other rationales for abnormalities as well. So we've spoken a little bit about aging here, and if you caught the session on Monday, and if not, there was a session that's obviously recorded to go back to on that aging process and how it affects mobility and seating as well. So I encourage that, but there are specific things that happen in the aging process that do affect the anatomy and the review that Tina did for us. And so we do start to see disc compression. We do start to see spinal fractures. That means it's not going to function the way that it primarily was meant to. Shortening of those soft tissues. All of these things do happen with the normal aging process. And so even if it wasn't a developmental issue that caused some abnormal postures or moving away from what's considered as the ideal, aging can do it as well. And that, depending on the path your health has taken within your lifetime, can happen at 80, or it can start to happen in your 30s or 40s, because if we're dealing with other things with our body physiologically, that aging process doesn't always follow the normal track either. The other thing that can impact is injury. So we do work with a big spinal cord injury population in our industry. And what you can start to see is some of these curvatures not being as normal, or more fused sections where we would have previously seen a lot of flexibility and a lot of movement because of fractures or because of surgical intervention that's been placed in that as well. There's lots of history and lots of background on where these abnormalities can come from, and getting to know each individual client and that history and not only what we see, but the why can help us move forward in that process for seating and posture. So I have up here the title, reducible versus non-reducible. Tina and I are both in the same area where we tend to fall on our terminology of fixed versus flexible, because it's very physical and you can very much visualize it, I guess. But we are trying to be good within our industry and move towards those more proper terminology that we're using of reducible versus non-reducible. I'll do a bit of the background. I mean, maybe everyone on here is better than you and I, Tina, and is using it, no problem. But I actually, every time I explain it, I'm like, oh, it does make so much more sense. And so this gentleman right here, we can definitely see that thoracic kyphosis that's occurring, I'm going to say because of age with this gentleman, but there I am assuming again, but we'll say it's that. The amount we want to see in the mobility that's actually there. So he does have a kyphosis, but are we able to reduce it? Are we able to get back to a bit more of that normal or that original positioning that we'd like to see the spine in? If we can, that is something that is reducible, right? We're able to reduce the issue that we're seeing there. If there's no movement, if we're stuck like this because of soft tissues, because of something going on with bone, it would be something that's non-reducible. The reason why this terminology is pretty crucial and why I end up liking it is because when we're saying it's non-reducible, we're saying we can't correct it, but we're not saying that it won't get worse if we don't intervene. And maybe this comes down to funding or letters of medical necessity, but we're really telling ourselves that, yes, we can't fix it, which is okay. There's lots of interventions that we can still do, but we want to make sure that we're putting and thinking into the future to make sure it doesn't get worse, because there are going to be consequences if this continues. And so that's where that terminology comes from. And I think it's a great reminder to our industry that, yeah, this disability or this developmental abnormality is here. Maybe we can't fix it, but let's see what we can do to prevent further issues coming from it. And there's a whole other slide on it coming forward, but it has to do with where does the person want to be now, but where do they also want to be in the future as well? Because yes, we're looking at this moment in time, but we need to consider our clients and their posture and their function and their goals that they have moving forward as well. So we want to take all this amazing anatomy review. We've just pumped you up to want to do that best for your clients. You really have to integrate it into your practice. And so I think what this program does and why I do end up enjoying it is that we can set ourselves to being client-centered, to moving back and starting at the beginning and seeing what was that developmental history. What is your seating and positioning history? What equipment worked? What didn't work? Why around your goals? So doing that really good background assessment, whether it is starting from birth and what the client has been through, or starting at point of injury or things like that, it really does open us up to realizing that a lot can happen, and a lot has happened with our client before they landed in front of us or before we met them 5 years ago for that first prescription. And then look at them today. So integrate that past that you've learned through that assessment and look at where we are today, as well as in the future. And that's really how we're going to find that match between equipment and client. We learn there's not a lot we can do at those smaller joints and those smaller anatomical features, but we do actually get to move forward and help our client in a way. And that whole history is going to help us actually match that equipment to the client to have those better outcomes. Assessments, you just need to find the one that you really like. So we've put a link here. It is the one that's up on the NARTS website, the Wheeled Mobility and Seating Evaluation. I know there's a few different versions of this out there. The reason why I like it, guys, it has the photos of all those tilts and the obliquities and the spinal curves. And so as you're going through it, not only is it a great checklist to say, did I cover all of these different options with my clients? It's going to remind you that pelvic obliquity to the left when the left side's down or when the right side's down or all that sort of stuff. So it not only tells you and uses the terminology of reducible, non-reducible, it's going to give you those images to really help remind what's going on with my client. What do I need to identify? It also does then go through a lot of equipment options as well and where you want to head, whether it's manual mobility, power mobility. So I know a lot of facilities use their own and select their own assessments, but they will, yeah, if you don't have one, or if you want to branch a little bit deeper for your notes, and so you don't have to write it all out or type it all out, I guess is what we do today, you have that there. Someone did just ask if I can post the link for that. Well, I'm sharing my screen. I don't think I can, but if you Google Wheeled Mobility and Seating Assessment NARTS, You will find it, no problem. Or reach out to me at the end and I'll make sure we have it.
Ali, I think I can do it while you're.
Oh, well, Tina's good like that. Oh yeah, someone said it pops right up when you Google it, which is always Ali's solution to everything. So here's just that other slide. So determining those current and future goals, right? It's important to think about the future for our clients too. And when we get into just looking at some backs and cushions as well, you'll really understand that, are we looking to reduce something? Are we looking to correct something for our clients? Or are we really trying to accommodate it? Like that one photo we saw of Tina's client in the past, where we allowed the pelvis to be in that non-traditional position, but it allowed actual functioning for the rest of his body and his goals specifically. Obviously, we want to look into progressive positioning. Are we going to change things and really try to reduce some of these issues that we're seeing with our clients, whether it is the pediatric population, whether it is the older adult population? Maybe we're using devices that can actually change as we start to see positive progress with our clients, to be able to help with some of these conditions. And that does need to be considered. And sometimes that's a bigger team conversation with people that aren't just within your specific designation, but it's going to work into positive progress for our clients. Considering function, considering comfort, skin health, of course, we have to take it all into play. And that's where that really good assessment does come into that.
Yeah, and I think it's important to take that and then move it into your equipment selection. If you could go back to the other slide for a second, Ali, I just want to mention, like, this case is Christy Hamstra did this case and shared it with us. And you can see that this person has a scoliosis. There's a slight obliquity. They don't look perfect, right? But this is I'm going to get the age wrong, 15-year-old girl who was, before this chair, in a chair that was 3 or 4 inches wider than that. And remember also that as we start to switch into talking about keys to equipment selection and helping with this kind of control of posture, is that if we get it wrong, we can actually facilitate more problems. The size of the chair and the position she had to be in to be stable actually probably didn't help to limit the scoliosis that she was starting to develop, right? It might have helped cause it a little bit. So we do have to be careful about how we apply the equipment. And we're going to go on to the next slide and start talking a little bit about equipment.
And it's a big reality. Like, this case study is not one off. Tina, our first case study we did together like 5 years ago, same thing. We did the good therapist thing, and we got the client out of the chair and his scoliosis disappeared. We were like, that's interesting. Let's dig a little more into why that appears when he is in his mobility equipment that was specifically prescribed to him, and why it disappeared when we got him on probably the most uncomfortable kitchen chair in the world.
Yeah. You guys, just before, so you guys know, someone asked to post that link in the chat. So it is posted in the chat. You just might have to scroll to it to find it, because there's been some chatting going on. And with that,
yeah, so we'll move in a little bit. I'm just being conscious of the time here. So we'll move into what can we actually do? The reality of, great, that was a lot of great background and a great review, Tina and Ali, but like, now what do I do moving forward into equipment selection? And so within our industry, you can sort of break it down into some primary supports, our backs and our cushions, our seated surfaces. And then you can have your secondary postural support. So whether it's add-ons for positioning, for pelvic support, or trunk support as well. And we'll introduce this guy, Tina.
Yeah, so I always like to look at, the first thing is the fit of the chair and really making sure that we get it right. If you take a look at this gentleman, go ahead and click, Ali, to the next picture. His problem wasn't that he didn't have the range of motion and didn't have the function. His problem was that he was actually measured incorrectly for his first chair. If we had left him in this chair, that could have become non-reducible. So you really have to be careful, especially with someone, say, with a new injury, is we do want to try to get it right as close as possible the first time, so that we're not contributing to these things. So this gentleman, it was pretty easy to correct him, and he had a very flexible spine and he was comfortable in that position. We reduced his pain and reduced his problems, by simply shortening the seat depth and bringing the backrest forward and changing the position of the wheels. So you really have to understand first the fit of the frame itself. Consider the wheelchair as part of the positioning, right? A lot of times we think about the mobility base, and with power, you kind of do that, right? Because it's a separate mobility base. With manual chairs, the mobility base, the frame, is part of the positioning. So you don't want to consider it, here's a chair, I can use any chair, but if I put on the right parts, it will be okay, right? So they looked at this guy and he's really tall. So they measured the seat all the way to the back of his popliteal fossa, left no room for his knees to flex. And it's an easy mistake that I see a lot in places where maybe they're not doing seating and positioning as a regular part of their job. So consider the frame, if you're using manual chairs, as part of the positioning device, because you can go a long way and make it incorporate better with the other primary and secondary components.
I don't think you paid that guy to smile that much in his after.
No, I did not. Yeah, you can really see the difference in his face.
All right, so we'll dive a little bit. I mean, this is probably the most generic slide you'll see here in this presentation. But all it's really telling us is that you do get to choose those back supports, and we'll go to cushions on the next slide as well, but specifically to fit the needs of your client. We cannot manipulate at that small facet joint level. We can't play in how much fluid is left in our discs, but we can now look for finding that perfect piece of equipment for our client today and for the length of that funding time, as well as hopefully in the future. You don't want to be switching types of backs every 2 years or 3 years if you don't have to. And so this is just a diagram, a few illustrations taken from backs within our industry. Obviously, we're not touching on custom seating here today, though it's a great option if none of those off-the-shelf options do work for a specific client. But there's a lot of customization between manufacturers, or even within manufacturers between their different product options that start to suit different needs. And so really understanding not only width and depth of backrest, but where those width and depths and the lengths of the backrest come from. If someone's just saying this is an 18 wide back, where is that 18 measured from? That typically just means, just so you know, in our industry, it fits an 18 wide wheelchair. How much room does it leave my client? Where does the support come when it comes to that width? Lateral positioning, especially, you can see just this diagram on the top here, that one back support comes in a smaller lateral option within the middle there, and it comes in a deeper lateral option. And this is a manufacturer that will actually tell you specifically where are we measuring those depths from, and then of course what are those actual depths for this particular model. And so when you're getting into that good assessment with your clients and really saying 5 inches up from the ITs, I need to start to have a lateral that's going to extend 4.5 inches out beyond this point, we can really start looking to our manufacturers to say, how are you building this equipment and where is this support going to come from? And therefore, is it the right product for my client? If we were in a real world trade show right now, you could walk around the booth and a lot of back supports look the same, right? They have laterals, standard, deep, they're all tend to be pretty black. But there is a lot of differences between them, and we don't always have the opportunity to lay 5 different manufacturers' back supports out, but it's sort of just that note that they do have that information, and you can get those spec sheets on these back supports, and it can really help make those decisions. And then of course there's ones, moving to that photo more on the bottom, where you can get some customization out of what could be considered an off-the-shelf back support as well. And this may be where we're going with some clients if we're going to start to see some progress, either in a positive way, unfortunately in a negative as well, but it needs to happen. Cushions are the same. They're out there. We won't go into too much detail, but each cushion's made differently from a manufacturer based on some normal anatomy and function within a client. But then there's cushions that vary and can be customized to some of those abnormalities that we see as well. So it's just really showing that these spec sheets are out there on devices, and this is what we can start paying attention to reflect our assessment that we did with our clients to really find that perfect match.
You also need to consider secondary postural supports. I worked in spinal cord injury, and there was a real like standoffishness about secondary postural supports with the users, and even with me as a clinician, like, well, they don't really need that. But I think it's really important to consider them if we need to ensure long-term positioning, facilitate stability and active motion, because sometimes a secondary posture support, even a postural support belt, it might be really low profile, but it might help facilitate someone's reaching or someone's sitting up longer or being able to do different tasks. So it really helps maintain a safe dynamic positioning and can contribute to improved function. So don't shy away from them just because of diagnosis. Really take a look at what their needs are and what their functional tasks are going to be during the day. And sometimes it's even, I have users who use them sometimes and not all of the time. So I think it's important not to forget about that. Again, I will admit that I often did. We also want to remember, because we're going to try to finish up here. Can you advance the slide, Allie? Sorry, I'm trying to advance the slide, but it doesn't work on my end. Is that needs change over time. So this is one of my favorite little guys that we've been following at Body Point. I haven't actually met him face to face yet, but Owen is, I think he's 8 years old now, and we started seeing him when he was 18 months old, and even his chair has changed, his postural supports have changed over time. So it is really important, if we can, to follow our clients, whether they're as young as he is, or if they're older clients, over time, to kind of see what needs change and how we can apply those different supports, whether it's cushions, backs, frames, secondary supports over time, and those needs will change. Lastly, why does it all matter? We can only impact gross movements with external devices. So remember that when we go back to the anatomy part, people have different anatomy, and we need to be prepared for those variations. Again, talking about reducible versus non-reducible. Do they have developmental abnormalities that we're not going to change? And that correct shape is key to promoting functional seating, whether it's the seating surface, the secondary supports, the back shape and contact area. So again, like trying to force a lumbar curve where there is none, maybe that's not the right approach, for example. So let's just quickly review, just because I always like to bring it back to where we started. So again, this model of the spine is an adult weight-bearing adult who has developed those lumbar lordosis and cervical lordosis. Remember that we're affecting a system that's a complex system of articulations, and that motions don't happen just by what we see. So every time we see flexion or rotation, we're seeing all of those motions in the spine. So you'll see rotation, flexion, and lateral bending are all happening at a small level, even though we might not be able to see them. And it's going to impact the function and position of the upper extremities, which I think is one of the most important things, because that will impact everything that person does, from driving a power chair to pushing a manual chair to being able to feed themselves and things like that. So we can't address one area without considering that entire chain of the spine, and we need to look at it over time. So with that, there's some questions in the
You've kept a pretty good eye on the chat. There was one that came up that I'll point your way, and it's probably might be
the ergo seat.
About ergo seats, yeah.
Yeah. So someone asked about the ergo seat. I have used the ergo seat, which is basically it's built into the frame. So it's what it's allowed me to do with some clients is to be able to take out some seat slope for positioning and get extra positioning from the frame that maybe I can't only get from the cushion. I use them sparingly, because one difficulty I have found from the ergo seat is that you have to be able to transfer out of that kind of bucket in the frame. So if they don't have the ability to do a good transfer, sometimes it becomes a barrier. But it is a great thing to try. And it doesn't mean that the frame's not adjustable. It just means that the slope of the frame basically becomes not adjustable. But you do have to be careful that it fits their pelvis and they're sitting in the well of the ergo seat.
Perfect. Our emails are there for any follow-up questions. We're always happy to chat, and I'll second pass it over to Becky there. I know she put the CEU code in.
Yeah.
Yes, I just put the CEU code in the chat. For verbally, it is SDTT5V. And feel free to, like they said, pass any questions that you have along to their emails. And thank you for a great presentation, Tina and Allie.
Yeah, and I would just like to give out a shout out to someone named Sammy on the chat, because I would like to use your quote that you said about gravity. He said, we can use it or lose to it. And that's very true, especially when it comes to seating and positioning. You put it much better than I would.
I'm
Thanks,
losing to it
guys.
these days.
Yeah.
Thanks, everyone. Have a great day.
Thanks.